go back to community banker, but good afternoon.
Good afternoon.
All right. That's much better. I didn't know I'd have the whole bio there. I'm sorry, it's a tough year as a Gator fan. As Corey, thank you. As Corey said, I'm Kyle Baxter. I've had the privilege for the past 4 years to be president of Palm Bay Hospital. I want to thank you for your warm welcome, and it's a privilege to be here and to see the incredible work that the Chamber does, support local businesses and families, continuing growth in Palm Bay. A little bit about our hospital. We're currently 4-star rated B. We want to be 5-star A. Some of the challenges that we're facing right now is the growth in Palm Bay. Health First, we share the commitment to building a strong and thriving community. Palm Bay continues to grow, with population increase projected by 2030 to grow by 14%. I've got a caveat down here. FP&L says we're already above that at 140,000. I'm sure it continues to increase, so our numbers are a little back there. Because of this, we're making investments to growing our services, expanding our services, investing in the future of healthcare right here in South Brevard. I'm proud to share an exciting and transformational update. A $230 million expansion of Palm Bay Hospital is officially underway. We're in the tail end of schematic design right now. The project is a major step forward, not just for Health First, but the entire South Brevard region. Our goal is simple: deliver more advanced, more accessible care to meet the needs of our growing community. So what's coming? Coming online at the end of 2028, 60 new inpatient beds, bringing our total to 187, with the ability to get to close to 250 beds. The top 2 floors are going to be shelled out for future growth. 8 new operating suites, doubling our surgical capacity, and all new. We're having to, we can't relocate or build where our current structure is. We're moving all of our operating rooms and 2 new cath labs into the first floor of this footprint, expanding life-saving care, upgrading support spaces for patients and families and caregivers, all designed to enhance the care experience. And that's really holding us back from being 5-star and A-rated. As I said, completion targeted end of 2028. This is brand new. I got this earlier this week. It won't be all white. Of course, we're not all white now, but you can see dramatically transforming the look of the hospital. In 2009, expanded the current 3-story tower, working with the city for the ability to have this new 5-story tower, but really changing the look. This is not a really small community hospital anymore. This gives us the ability to add services that we don't have looking toward the future. As I said, population has increased. We're in a constant state of overcapacity today. This certainly helps us deal with the capacity we're seeing, the ability to plan for future growth as well. But this project is not about expanding capacity. It's about delivering care that's more responsive, more specialized, and more convenient for our neighbors in Palm Bay and across South Brevard. It also means new local jobs, healthcare innovation, and stronger foundation for longer-term community wellness. We're proud to be a part of the solution, helping reduce travel time for patients, improving outcomes, and ensuring that world-class care grows right alongside the city of Palm Bay. Throughout this process, we've worked closely with local leaders and community partners to ensure the expansion reflects the Palm Bay truly needs. As your local not-for-profit health system, every decision we make is rooted in community partnership and local investment, not shareholder return. Our shareholders are you, the community. We're here for one reason: to serve the people of Brevard with excellence, integrity, and compassion. We are good stewards of the resources entrusted to us, which allows us to plan for expansions like the ones I've shared. Community support is essential and your support advances implementation of services, enhances patient care programs, and empowers clinical excellence. We can't do this all by ourselves. It takes a village for everything. I would be happy to connect you with Chris Kern, our Vice President of Philanthropy. Chris would love to learn about the areas you're interested in and explore ways philanthropy with us can enable our mission to serve this community. She would have joined me today, but she's actually meeting with a donor at my hospital right now, covering for me, because I double booked myself. But we've got a broader vision for Health First. While Palm Bay is a major priority, it's part of a larger vision across Health First. Increasing inpatient capacity at homes and Vieira Hospital, expanding emergency services, including 2 new freestanding ERs in Rockledge and South Brevard, opening in 2027, strengthening our first flight air ambulance program to improve trauma response across the county. And this year we launched Epic, a best-in-class electronic health record system that connects patients to their care like never before. Couple of shots of the new Cape rendering build. It's a mess right now because of construction, but this is going to be a beautiful state-of-the-art 120-bed facility that my friend, president of Cape Canaveral Hospital, Andrew King, had surgery by Dr. Hammoud coming up next last couple weeks ago. It's not a HIPAA violation. He told me I could say that. Beautiful facility. Because it's all brand new. Ours is a little bit different in the footprint. Vieira Hospital, certainly both Cape and Vieira have seen a 20% increase in ED visits since the closure of Rockledge Hospital. Understand why they did it, but Vieira is going to have an opportunity to expand their service as well. Growing community just like Palm Bay. Great shots of our 2 helicopters now. There's been multiple instances where both helicopters have been responding to issues within the county at the same time, and we didn't have that ability to do that. We called for help from Orlando. We don't want to have to do that anymore. A couple shots of the renderings of our freestanding ERs. And before I kick it off to a better than average golfer, a great surgeon, and an excellent human being, Dr. Hammoud, at the end of the day, this expansion and every investment we make comes down to one thing: our commitment to you, our community members. We are not just expanding a hospital, we are expanding access, trust, and care in the heart of a growing city. And thank you again to the Palm Bay Chamber for your leadership and partnership and your belief in what's possible when we work together. And now I'm pleased to introduce Dr. Mohamad Hammoud, a leading general surgeon at Palm Bay Hospital.
Good afternoon, guys. Kyle told me it's going to be a quick thing and 20 people are going to be here. He knows I don't like to talk in front of people, I like to operate, but I really think this topic that we're going to talk about next is really important, at least to share the technology and what we do at the hospital. You know, a lot of people go to the hospital, they don't know what's going on in there. Actually, I've met several people I've operated on in this room and some family members I operated on. We want the best care for you guys. And that's coming from the heart. We want, when you as surgeons, we want to be able to go home, sleep at night saying, you know what, we did the right thing for this patient. And I think the robotic program that we started at Palm Bay has expanded dramatically, has done that for a lot of patients. So this is just a little bit of myself. Basically, I came to Palm Bay 7 years ago. I was in Michigan, I trained, and one of my friends from the other side of Orlando said, hey, you want to go to Florida for a ride? And I came down and I loved it here. I loved the weather, and I said, you know what, I'm going to work here. And Health First was the first to contact me. And since then, I met my wife at Holmes Regional. She's a nurse practitioner, and we have 3 kids now. Basically now, 80% of my cases are done robotically. We just hit over 1,000 cases not too long ago. Just so a little bit about surgery. So there's, modalities, open surgery. Basically, we cut you open, and if you had a gallbladder, we just take it out open. That was the best technology we had at the time. Then we went to laparoscopically, where we do little incisions, but still, the best way I describe it as a surgeon is like operating with chopsticks. You can do the surgery, but it's very difficult. If you ever try to eat and you don't normally use chopsticks, it's very difficult to do so. Even if you become an expert, it's certain things you cannot do unless you have a fork or something a little bit more complex. So that's where robotic surgery comes in. I'm still doing little incisions, but whatever I can do out here, whatever my hands can do, articulate, suturing, the robot will mimic on the inside. And what I want you to know is the robot doesn't do anything. It's the surgeon doing all the work. The robot is just a tool we use to make my job a lot easier. So this is a picture of the robot. Over here we got the robot way on the left, and Intuitive is our robotic platform that we use. Da Vinci is the robot name, Intuitive is the company. There's more robots coming online, but as this is one of the best programs, the best robots we have. So the patient cart is basically where the robot goes over the patient. The one in the middle there is where I sit in and basically put my fingers, put my head in. It's like a 3D visualization, and anything I do with my fingers here, the robot will mimic on the inside. We basically put little instruments in with little straws, I call them, they're called ports, and then anything I do over here, the robot will mimic on the inside. And then that tower is basically how we can see I got my own thing, but the nurses will see from that tower on the side there. So basically, this is, for example, this is a hernia surgery. So I don't know if anybody ever had hernia surgery. I'm sure you know somebody had hernia surgery. But basically, hernia is a hole in the muscle there, and you got to fix it. But without mesh, it's not gonna work. Suturing is not gonna hold. So you need to put a mesh in. So the old technique is make a big incision and put a mesh in and suture it in. The problem with that is it does a good job, but the biggest thing for me is the incision is right over where the mesh is. So that mesh gets infected. If you should heard the commercials, it could be a disaster. Here you can see, it's hard to see it down here. 2 to 3 little incisions, usually 3 incisions we make. We do the same exact surgery. So the reason this is, obviously for me, a mesh infection was what keeps me up at night. For you guys is recovery, getting up, moving around, walking, getting back to work. Here, you're back to work. Some people go back to work at 3 days, on average a week. Over there, you're looking more like 6 weeks, 8 weeks, maybe even longer. Another surgery I do a lot of is gallbladders. I've seen a lot of people putting gravy on, so we'll see you later. But in all seriousness, this is one of the most common surgeries in the world. We used to do it big open surgery. Now we do it, most people do it laparoscopically. I do all my robotics, all my gallbladders robotically now. I have 2 robots, thanks to Kyle and Intuitive. So basically I can go from one room to the next doing the robot instead of doing it laparoscopically, because I truly believe this is the safest surgery to do it. Now some surgeons will tell you, well, it's not. And the reason is they don't have a robot. And number 2 is they're not trained on the robot. It takes a long time to get to this, the skill level. It's the same surgery, but the robot's a little bit different. So it takes a long time. So some people do not want to try new technology, and that's okay. I'll do more robots. And so basically, the biggest thing we look for, the anatomy, and if you look at the picture on the right over there, it's very difficult to see what you're seeing. But I got, we got a medication we give, and then we go through this we call Firefly mode, and it basically shows me all the anatomy. These are the ducts I don't want to mess with. I think this is the point. So this is the duct I want to cut. This is the duct I don't want to cut over here. So, if you cut the wrong duct, this is, the patient's going to suffer. We have to transfer to a transplant surgeon and fix it in Orlando. Their life has changed forever. And like I said, we do a lot of these surgeries, and if you do enough surgeries, you're going to get a duct injury. But this is the technology is not allowing this to happen. And it just takes one person in this community, and it's going to change your life forever. So like I said, smaller incisions, less pain, shorter hospital stay, faster recovery. People get back to work quicker. And I'll give you 3 examples within the last 2 weeks that occurred. I had a 23-year-old male, had a perforated appendicitis done in a different hospital. Came back, he had a bowel obstruction. Basically, he had a pus pocket that occurred after the surgeon did it laparoscopically. And the intestines was stuck in the pus pocket, as we call it, an abscess. And any other surgeon, if they didn't have the robot, would have cut them open. You end up losing some of your colon and reconnecting it. And that's the guy got this big surgery, lost half his colon, where I went in robotically, 3 little incisions, about 30 minutes, and I was able to break all that up and take care of the problem without any resection of any intestines. Without the robot, I truly believe he would have ended up with a way bigger surgery than he needs. Now, if he goes to a hospital that surgeon doesn't have the robot or he's not trained, that's the best technology at that hospital. So, and I believe, at Palm Bay, we have the best technology. Another example, I had a 95-year-old male, and And this is a very common theme in Florida. We obviously see a lot of older population, retired population, which I didn't see this in Michigan. Michigan, the group, they're a little bit younger, a little bit bigger though, because no access that much in Michigan. Basically, 95 with a right inguinal hernia. And a hernia, like I said, a hole in the muscle there where basically his intestines was going down into his scrotum. And they can't walk. He could physically do everything normal like we can. He wants to go outside and work in his garden and destroy his life. An open procedure is not really a good option, and most surgeons will not take him and say, you know what, you have to live with the pain, I'm sorry. Try a belt and see if it works. And that's what we used to do because the surgery is so risky that it's not worth killing the patient, saying, you know what, suffer with pain. So basically it was a 20-minute surgery, robotically, 3 little incisions on the top, just like the picture you saw earlier. And he was out of the hospital the next day because the time it took me to do that surgery was about 15 minutes robotically. Because anything I can do out here, I can do on the inside. And it's a way quicker repair. And these are just the prime examples that you will never see, in the books, no one's gonna ever talk about. But saving, this guy is gonna have a great life now. He's gonna be able to go see his grandkids and do his gardening, which we really don't think about. Or if you're working, everybody has to work, right? And you need to be able to lift. So this will get you lifting quicker, doing what you do for your job a lot quicker. So just a little bit, I have an office here in Melbourne, and I have one in Palm Bay. Any questions? I'd love to take some questions. Nothing technical about the robot itself, but I'll tell you how to work it. So the one thing I didn't mention here is the telepresence, which is, I think, the coolest thing. We had the new we have an older robot and a newer robot. Pretty much the same, a couple more things that come in with AI and stuff like that. The best thing is now I have literally a surgeon can come in live with me. So and you guys can too, actually. So anyone, I can invite them to the surgery, and on their phone, they're live in the surgery with me. And anything they say over the phone is live throughout the room. They can hear me. So this is great for other physicians that say, hey, what are you doing with that surgery? Well, let me show you. Come on in live with me. Or another surgeon, like for me, for example, we were trying to get some of our homes surgeons online with the robot. And so you got to get trained. And it's hard for me, I'm a busy surgeon, I have 3 kids. It's very difficult for me to go to homes, and I'm taking calls at Palm Bay. So I can go in live now from my house on the phone, or I'm driving in the car, and give them advice, hey, this is what you should be doing, this is what you shouldn't be doing. Or vice versa, they can come in live to my surgeries and see how I'm doing and what I'm doing. And it's gonna change the world, because now, like, for example, there's surgeries, I do colorectal cancers. And some of the surgeries, colorectal cancer is really difficult. These are difficult cases. They take a couple hours, but we can do them all robotically. We used to do big incisions, now we do 3, 4 little incisions. But I can literally, Dr. Salman's down the street, he's in Orlando, he's a world expert on robotics, he's a world expert in colorectal surgery. I can give him a call, and he can literally go live and say, hey, this is what you should be doing. So if I need the training, he's available. And definitely it's gonna change the future, and the technology is gonna get you more adaptive and a lot more complex. It's gonna eventually help everybody else out here. And that big surgery that we, now instead of like doing a colorectal surgery, little incisions, that's gonna save us hernias, scar tissue formation, bowel obstructions, and these are what we see a lot of patients back 20 years from now, 10 years from now. And I'm sure some of you guys had some of those surgeries too. So I'll open it up for questions.
Welcome Dr. Antaki, one of our other robotic surgeons. He's also an open heart surgeon at Holmes. For our talk. Hopefully we didn't run out of time, Dr. Antaki.
Thank you very much.
Thank you very much for the opportunity. I'm also going to invite to the podium my APN, Tabitha Haynes. She is a crusade that goes basically around and trying to eliminate lung cancer all the time.
Thank you.
What we want to talk about is the role of robotics in thoracic surgery, but in reality, I think what's more important is what lung cancer is and its effect on our community. The truth is that lung cancer is a very important issue, and of all the cancers, it is responsible for more death in the United States and across the world. If you take all of the famous cancers, breast, prostate, and colon, and lump them together, lung cancer still is responsible for more death than all of them combined. And we all know the effect of smoking, and unfortunately smoking continues to be a major problem in our community, and including, as a matter of fact, youth. Despite all of the efforts that the society has, education, everything, about a quarter of adults continue to smoke, and also there is a rise in the rate of smoking among youth, particularly also vaping. Vaping, in my opinion, and a lot of clinicians actually share that with me, I think vaping is even worse than tobacco smoking, because now we are seeing a lot of young people showing up with major injuries to their lungs, and we don't know what's going to happen to them when they are even older. But even at young age, we're seeing a lot of that stuff happen. Florida continues to be also a high smoking rate, as well as a high lung cancer incidence. And about a quarter of people diagnosed with lung cancer will end up surviving the cancer 5 years later. That means 75% continues to die despite all developments in management of cancer. The statistics, like I said, are still pretty bad. More importantly is the idea that despite how big lung cancer, it's still not receiving the attention that it's needed when it comes to early detection. Breast cancer, we all know the importance of early detection. We know that there is a lot of support towards actually early detection of breast, as well as colorectal and prostate. Almost every person will end up have to go through a detection process, but nobody really cares that much about all these high-risk people, heavy smokers, and if somebody is checking for cancer. And for this, I would like to ask Tabitha to help us actually talk about what she does. This is something that is quite dear to her.
Thank you. So at Health First, we do offer a lung cancer screening program. Primary care providers, pulmonologists also can order lung cancer screening CT. The important part here is to know who's eligible. Patients over the age of 50 with at least a 20 pack year history are at an increased risk for developing a lung cancer. So those patients really should be screened. The other caveat that a lot of people miss is that they have to have smoked within the last 15 years for insurance to have paid for it or cover it. The cool thing that we do at Health First is you can self-pay for a lung cancer screening CT. It's about $150 out of pocket. Even if you don't meet this criteria and you want screened because you have exposure to mining or radon or strong family presence of lung cancer, and you want to be screened, you don't have to meet that criteria. We can get you a self-pay form and we can still do the CT. The other thing I also mentioned is if you've had previous chest imaging, say you went to the emergency department concerned for chest pain or pulmonary embolism or something of that nature, if you've already had a CT within the last 12 months, you don't need a low-dose CT. And the cool thing about the lung cancer screening CTs is they're a fifth of the radiation as a regular chest CT. So that's really one of the benefits. If you're at all interested in this, we can get you information. Patients can self-refer to the lung cancer screening program. So if you have a loved one that wants to be screened, I'm happy to chat with them. And then this is sometimes what we find with the lung cancer screening CTs. These are different nodules. I don't know how to work the blinker right there and right here. And then I'm going to turn it back over to Dr. Antaki so he can tell you what we do when we find those lung nodules. Thank you.
So nodule essentially is a small mass. And this is what we like to discover is something that is as small as possible. And when you order one of those scans and you go and have one of those scans, many times you get the report back to you, talk about a nodule of 2 millimeter, a nodule of 3 millimeter. Usually these are low risk. I just want to reassure people when you get that report, especially on your electronic chart, patient reporting system, that's not that high risk. What is a source of concern and a call for action will be something that is in the range of 6 millimeters or higher. So that starts a process of investigation. And this is where new technologies and evolutions in detection and early detection in procedure come into play. This is where the technology of robotics has been very helpful in allowing detection of tumors that are quite in the very early stages, in the 6 to 8 millimeter, 1 centimeter. This is where you can have a high rate of cure in these cases. So one of the such technologies is robotics as well. So if Da Vinci is big brother, this is now the younger brother. This is Ion Robot. And the idea here is, if you go back and take a look at this scan, you can see that what we are after is this little dot in the middle of the right lung. This dot is about 8 millimeter wide. The lung is a big space. The lung is about 1.5 gallons. And for you to find it requires the use of a lot of triangulation science. This is where GPS technology, shape recognition, sight recognition, a lot of the even defense type of technology that is something that we actually are familiar with in this county actually comes in play and is used actually for healthcare. So essentially, for me to be able to get to it safely and get a good representative sample, I will have to use GPS and I will have to use robotics. So the device we're looking at is the following. Essentially, this represents a catheter. We call this catheter a robotic scope. It goes inside the airway of the patient. The patient is asleep. The patient has a breathing tube. This robotic scope goes inside the endotracheal tube or the airway of the patient. And then the surgeon essentially drives that GPS-directed robotic scope using this, more or less, it looks like one of those video game controllers, essentially. It allows you basically to push through and get safely to the location. This technology, believe it or not, is the third or the fourth iteration of development of navigation bronchoscopy. We started with navigation bronchoscopy about, I would say, 16 years ago. And when I started using it, I was using something completely different. It was GPS-related electromagnetic orientation inside the body. This technology now is a bit different than that. It's more precise. In the past, I was able to get positive diagnosis, precise positive diagnosis of small lesions in about 80% of cases. Nowadays, most of the centers score up at the 95-96% detection rate. So this is extremely important. If you discover an 8 millimeter tumor, that means this person is going to be alive more than 5 and 10 years. Chance of that is higher than 90%. So this is extremely, extremely good. This is what a typical procedure look like. The operator over here is introducing the biopsy instruments inside the robotic scope, watching everything on monitor over there. This is a display of the process over there. This is one of those procedures that we did. You can see over there, everything is displayed in a virtual manner. It's very similar to when you are driving your car and looking at the GPS, and you can see where your destination is. So this is the destination. This is the route to it. And you can see over there that it looks like we've arrived at destination. The scope is showing you the inside of the airway down here. This is telling you how much distance you are from your biopsy site. So you got a lot of information here to help you get a high detection rate with the minimum invasion and least complication rate. When we do these procedures, it used to be we would actually send patients to interventional radiology to have a CT guided biopsy, which essentially means patient will lie on a scanner and the scan is done, and then the radiologist will bring a needle and kind of drive the needle inside the patient's chest and keep adjusting it according to what they see on the scan. It's a good procedure, good detection rate, reaches up to the 90%. Unfortunately, you can imagine what will happen to the lung when you drive a needle through it. There is a risk of lung collapse. The lung will start leaking air and collapsing. Over here, you are working inside the lung. You're less likely to puncture the outside of the lung when you do that, and thus the rate of lung collapse drops down to almost zero. There are years we go doing this procedure without getting any lung collapse. So this is very helpful. Very good. So essentially, this is basically it. Like Dr. Hammoud said, also we do use Big Brother for lung resections. So being able to get inside the chest and remove a lung tumor without making the traditional big incision is a major development. I thank you guys for the opportunity. I just wanted to make sure also you understand that the human factor is always important. So all of these technologies are possible basically because of cooperation among people. One of the things we do regarding lung cancer management in our center is basically have what we call tumor board. Essentially got specialists discussing cases. Each and every case is covered by multiple specialists together. And thank you very much.
Thank you.